of the mechanism of action of our drugs is one wherein we had a view that there was something wrong with the neurotransmitters serotonin, norepinephrine, and dopamine in the brain. And from that, we then developed medications that target those systems. And that resulted in some very good outcomes for many people. However, it did not result in good outcomes for as many people as we would like. And so we needed to really go in a different direction, not throwing the baby out with the bathwater. We still consider the monoamines as key targets, but there are other targets. I'm going to introduce those to you. It's a really exciting time. But I guess I brought the point up about cannabis. I just tweeted that last night. So join me on Twitter for the Journal Club. But it's a reminder that we really should be talking prevention. The best treatment for any medical problem is prevention. The best way to treat COVID is to prevent it, get the vaccine. And the best way to treat anything is to prevent it. And in psychiatry is unique in so many ways, which I find thrilling. By the way, this is the most interesting subspecialty of medicine by far. I unashamedly say that. It's so thrilling, this area. And I would say that if I was to put one criticism against my own profession, I would say I don't think we press the point of prevention as much as we should. We do in diabetes, we do in heart disease, any other area of medicine, we talk about prevention. I don't think we do it as much. And that's why I brought the point about cannabis. I mean, and we're concerned that this could be causal in some cases, not on its own, nothing's causal 100%. But it's just a reminder that when we're talking about mood disorders, these are conditions that are common, severe, lifelong for many people. And the question today is the same question we had yesterday, and that is, what's causing these disorders? And the answer is it's not entirely clear. There is a genetic architecture that is subserving this phenomenology, this condition. But genetics interacts with the environment through epigenetics, and that might be trauma. It could be insecurity of finance, housing, or healthcare. It could be exposure to discrimination, racism, social isolation, loneliness. There are many factors here that alone or in aggregate can increase the risk. And so I'm going to get right into talking about treatment, but I didn't want to not forget to mention that the best treatment is prevention. And I was telling an audience last week, 2 weeks ago, we had our American Psychiatric Association meeting took place, which is a big meeting in this field. And I was saying to an audience that we have a vaccination for depression, and that got everyone's attention. And I said that the vaccination for depression, guess what? It's called exercise. And there's been lots of data to show at the population level that if you are active, you don't have to be an Olympic athlete, but if you're active, that is associated with a decreased percentage of people who declare depression. Now, does that mean that that's the solution? Of course not. It reduced the risk by 10 to 12% at the population level. That's not 100%. But it's just an example of ways we're beginning to think about this. Another area we're beginning to think about this is in obesity and diabetes. And a bit later on, I'm going to cover this with you because when we talk about in children's schools taking sugary drinks out of the cafeteria, now when I was a kid, I used to drink a lot of sugary drinks. I don't anymore, but we know there's an obesity problem in young people, and not just young people, but young people we're going to focus on right now. And we've learned that young people who become overweight, obese, or diabetic are more likely to have depression. And it's not because, I have my self-esteem is down, therefore I'm going to get depressed. That would be an overly simplistic and reductive way of thinking about it. What happens with obesity and diabetes is it changes the body's chemistry. You become more inflamed. You have problems with insulin signaling, and then that leads forward to affecting the brain, which we're going to cover shortly. So prevention. Let's now talk about treatment, what we can do about it. I want to level set, though, for us all, if I can. And this is going to come out a little later on this year. The World Psychiatric Association is under the banner of the World Health Organization. And this is the global voice for psychiatry around the world, not just in the high-income countries like Canada, but the low-income countries. And in in the World Psychiatry Journal a little later on this year, we're going to have a guideline for clinicians all around the planet on how to detect, prevent, treat, manage depression and in mood disorders. And so this is a journal where you can access the articles free. So just put a little note to yourself. This will be posted September 1st of this calendar year and covers really the whole topic. Which I think for those interested, you might find this an interesting read. Okay. Now, let me actually cover a few things if I can. We know that depression is common in Canada, and the overall prevalence of depression, for the most part, has been pretty consistent in Canada and the United States up until about 3 years ago, 4 years ago. I started off my research career. I was a medical student, and I began working with researchers from Harvard in a community-based epidemiologic study known as the Sterling County Study. And this was a study where we chapped on people's door and we're trying to understand how common was mental illness in the community. That was a very interesting experience, I'll tell you that. Anyways, the depression has been in Canada cited, and I'm going to call it depression and bipolar together, as affecting around 5 to 10% of the population at some time in their life. That's a lot of people. In the United States, the rates are a little higher, closer to 20%. Depends on the survey, but 5 to 10%. Now, there's a little thing that happened the last few years called COVID. And we have seen in not all populations, but in certain subpopulations, not just in Canada, but elsewhere, an increase in the onset of depression. And that was especially noted in younger populations. So you all know that older populations were more susceptible to mortality from COVID. The mental health consequences of COVID were disproportionately experienced by younger populations, females, and also people who were unemployed. And I don't think those are not mutually exclusive, obviously. And so the point being is that we have seen an increase in depression. And so depression's common. We start off with that, affecting somewhere between 5 to 10% of Canadians, a bit higher south of the border. And once depression declares itself or bipolarity declares itself, certainly in the case of bipolar disorder, that's a lifelong disorder. You have it, you have it, you have it. For major depression, for some people, many people actually, they'll have an episode of depression and that's it. They never have an episode ever again for the rest of their life. And of course, that's fantastic. Other people have episodes that recur across time, and that would be the case for 3/4 of people. So the great majority would have recurrences. And when people come to see us, we aim to eliminate the symptoms. And no different than if you have pain, back pain, you want the pain alleviated. And we measure the symptoms with rating scales. And we've done a lot of research on this, looking at rating scales where you complete some of you may have been to your doctor, your nurse, and they ask you to complete these questionnaires in the waiting room. And that's the way we've done this, frankly, since the start of time. More recently, digital psychiatry's caught on in the sense that, well, digital psychiatry means different things. Digital psychiatry could mean something very well known, like telehealth, seeing your care provider through the Zoom link and all that. We now move towards electronic health records. We don't use paper much anymore. That's digital psychiatry. But where I'm going with this is more in the area of digital surveillance. And I know it sounds a bit George Orwellian, but is there wearables? Are there passive ways that we can collect data where we can track in real time whether or not you are depressed or not? And there's some really cool technology now, which is still very much kind of early development, using wearable type things, not so much a Fitbit per se, but sort of like that, where an app could track you and track everything from your texting, your geographical movements. It can look at the type of text that you're sending and break down the syntax and the vocabulary and create a digital signature as to whether or not you might be depressed. This is a very hot topic. And now, since everyone's talking about ChatGPT, maybe ChatGPT can figure this out. But the point being is using AI, using these types of machine learning approaches, there's a lot of interest that digital psychiatry might be able to assist in monitoring your mental health status. No different than devices now you can put on your skin that can, in a real time way, monitor your glucose levels if you have diabetes. So that's a work in progress. That's not prime time, but a work in progress. And then related to that, maybe digital therapeutics. For example, in the United States, the US FDA has approved a digital device to treat ADHD, attention deficit hyperactivity disorder. Now, it looks a little bit like a video game. It's not quite a video game, but it's sort of like that. And it helps the symptoms of ADHD. So we call that digiceuticals instead of pharmaceuticals. And so using technology to treat. So coming back to my point, though, is that we track symptoms. And the fact is that the great majority of people who are depressed, who take the treatment, whether it's psychotherapy or medication, they have a partial response. Now, about 20 to 25% of people have a full response. They just get completely better, back to school, back to work, take the kids to soccer. Their life is completely back. But you can do the math, 75%, that's not the case. They have an inadequate response or no response, a partial response. So that they're better, but they're not well. And obviously we want people better, but we want them well. And so having a little bit of depression is like having a little bit of cancer. You don't want that. And because this is still causing distress, it's obviously very difficult to function like that at your best. There's risks of other problems like becoming anxious or using illicit drugs if that's something you're predisposed to. The suicide risk could still be there. So we want people to get better. We're always struggling to figure out ways we can do that. And what I did just for empirical purposes is I want you all to kind of just to sort of see the kind of state of the union. This is in fact 4 different histograms, and it represents the likelihood that a patient will respond. Now, respond means they get a bit better with the first treatment in depression, 72%. What's the chances of responding to the second treatment? The first treatment doesn't work, 54%. And you can see the rest. I'm not going to say it. So one doesn't need to know much about the space. Say, hey, look, we're getting decreasing odds of success here as each treatment is tried and not delivering. And so this, for me as an academic, as a scientist, is raising so many questions. First of all, there must be more than one type of depression. There must be more than one type of pathogenesis. Secondly, there must be other ways to treat depression than just keep using the SSRIs or what's called the selective serotonin reuptake inhibitors, which are the Prozac type drugs. And it's common sense. Look, if you went to your clinician, and let's say you had pneumonia, you had bacteria in your lungs, and your clinician said to you, I'm going to give you penicillin. And you said, okay, that sounds cool. And you got penicillin and it didn't work. And then your clinician says, I'm going to give you more penicillin. And you'd say, well, the penicillin didn't really work. Is there any types of antibiotics that are different than penicillin? And that's the question, frankly, we were too late in asking, I think, in depression, because there's no doubt that penicillin works, but not for all pneumonia. And there's no doubt that the Prozac type drugs work really well for some people, but not for everybody. And so therefore we need new ways of thinking about treating depression. And that's why I want to bring this point up. And so this is a very, very common situation. Now, one point I wanted to bring up, again, I'm purposely touching on different aspects here because I appreciate that when you go to the shopping mall, you hang out at the shopping mall, everyone has different things they're looking for, different things they're interested in. And I want to touch on different aspects that our group's been researching that are really, I think, critical to formulating why people become depressed, how we can prevent it, how we can give people better outcomes, and what are some of the factors that are being talked about in the neuroscientific community. Now, here I'm raising the topic of loneliness. And one might say, loneliness, what's that got to do with neuroscience? Well, this has got a lot to do with neuroscience, actually. And in the United States, the Surgeon General in the United States is a person called Vivek Murthy. And he has been very vocal in the United States as the top doctor in the United States saying that the big pandemic of the United States is, in fact, loneliness. And in the UK, they have a minister of loneliness in their parliament, and which is also the case in Japan. To put a bit of color on this, and I think I'm probably preaching to the choir, I think this is really underemphasized, that loneliness is not the same thing as social isolation. They're correlated, but they're not the same thing. Social isolation is geographical, objective distance from other people, while loneliness is a subjective phenomenon that represents a disconnect between what the individual desires with respect to human connection and what actually exists. And I always make the point that someone can be home alone all weekend long and frankly not be lonely at all. I think we've all had times when we're left alone, and it's actually quite enjoyable. Other people are in a room right now with 30, 40, 50, 100 people, and they feel pretty lonely. So lonely is subjective. And it affects anyone, any age, sex, age, race, any group can be affected right around the world. This is a phenomenon, but especially prominent in older and younger populations. And I tweeted about 3-4 weeks ago, maybe a bit longer, data that came out of the Centers for Disease Control in Atlanta, showing that 2/3 of young girls in America are depressed, and 1/3 want to die by suicide. 2/3 are depressed, 1/3 want to die by suicide. And I made the point, look, I don't think there's not one explanation to that, but I think loneliness is playing a part in that. And there was some data that came out of Salt Lake City, Utah, at one of the universities there, about a decade ago. It was kind of a seminal paper, and they discovered something I think is really just mind-blowing, that people who rate themselves as lonely have not only more depression, anxiety, obesity, diabetes, and cognitive problems, but they have a shorter lifespan. In fact, the mortality rate in people who are lonely is not a lot different than someone who smokes a pack of cigarettes a day. So if you think smoking a pack of cigarettes a day is not good for your health, well, guess what? Loneliness has the same mortality statistic. So that's what inspired governments to really take this on. And it has a whole host of factors that are influencing this. And I bring it up because we did some work a few years ago, and we discovered that people who are lonely with depression are more likely to have inflammation. In other words, when we check their blood has markers, biochemistry markers of being inflamed. And we know that low-grade inflammation in the blood can cause depression. And what's interesting is that people who have loneliness are more likely to be prescribed psychiatric drugs, which is probably a proxy of mental distress and maybe the mental illness. And if people are lonely, they don't seem to benefit as well from some of the medications that we give them. And so I was telling an audience recently that, we're so interested in finding out what can predict whether someone benefits from an antidepressant. We're interested in genetics and all these sexy transcriptomic analysis and all of that. Well, frankly, one of the best predictors of whether someone's going to benefit from psychiatric medication is, do they have financial security? Do they have a roof over their head? Do they have a relationship with anybody? It doesn't have to be a romantic relationship, but relationships. Do they have any interpersonal connectedness? And so this is something I thought you'd find interesting, and has very powerful effects on brain health and disease. There's not one single mediator, but probably driven by inflammation and many other factors. This is a concept I want to leave with you as well, which I thought some might find interesting. And that is that I see a lot of people with depression. We've seen tens of thousands of people now with depression and bipolar illness. And their symptoms will get better, which is awesome, but they don't function much better. Let's say they're going to university, UofT, they can't do full-time course load, even though the depression has gone away. And other people who are in the workforce will say, look, I can't go back to work. I can't take care of my kids, this type of thing. And what's interesting is that for many people, even though the depression got better, they now can't seem to get quite back on the same track that they were on before. And if that's the case, that is, they continue to have ongoing functional problems like that, it increases quite significantly the risk of relapse of their depression, which is probably no surprise. And we've been scratching our head for a long time trying to ascertain what's going on here? If depression leads to functional problems and we treat your depression, it's axiomatic. You should go back to work, go back to school. But many people are not. And we don't have a simple explanation for this, but we have a couple of leading candidates. One is that depression often leaves people with lingering cognitive problems, almost like a scar, if some use that as a metaphor. There's like a scar where they can't focus the way they used to. A lot of people I will see after they've had a couple of episodes of depression, they'll say, hey, Dr. McIntyre, do you think I got ADHD? They might, but most times they don't. What they're really saying is I got these new cognitive problems. I can't even focus. And that's the scarring effect of depression. And related to that, but different, a lot of people are just tired all the time. They can't get rid of this tiredness. And that's also something that lingers very often between episodes, and something we're trying to focus on. And this is what's called anhedonia. And when we think about depression for most people means the person's sad, they're weepy. I'd have to say that many people I meet who are depressed are not depressed. People say, what? What are we talking about? And a lot of the patients I meet, I'll say, oh, Mrs. Jones or Mr. Jones, I'll say, listen, I think you have depression. They'll say, really? I don't agree with you. I'm not even depressed. And I say, I know. I say, well, how can I be depressed? I'm not depressed. Well, a lot of people who are depressed don't feel depressed at all. They don't feel great, but what they feel nothing. They just feel like life's not interesting. They're not motivated. They're not feeling much get up and go. They're fatigued. We call that anhedonia. And anhedonia is the absence of pleasure. But it's more than that. It's the lack of motivation, the lack of what we call incentive salience. In other words, all of our activities as animals is contingent upon reinforcement, just like the old, classical conditioning and reinforcement. And that reinforcement for everyone's different. And if the reinforcement effort is too much, at least according to the person who is making that calculation, let's say, the heck with it, I'm just too tired. And depression is not only a disturbance in how you feel with respect to your mood, it's also a disturbance in the reward, the color that you bring to your life, that you bring to your cognition. And it's highly linked to suicide. Emily Gillespie actually is a student of ours, and she did this wonderful paper with us this year looking at suicidality. And one of many, many students over the years who's really been very productive with us. And as I said, there's opportunities for students to join us in this regard. And we were interested in suicide. Who isn't? And what we discovered was anhedonia is not just common, the absence of pleasure, fatigue, tired, lack of motivation, but it was really linked to suicidality. And this concept called anticipatory anhedonia. How much pleasure can I anticipate? See, pleasure is either consummatory or anticipatory. Do I enjoy a cup of coffee with a slice of cake? That's a very basic example of consummatory pleasure. Do I enjoy meeting a friend for a cup of coffee? That's consummatory anhedonia. But to look forward to something, that's anticipatory pleasure. And when you have an impairment in this domain or subdomain, the patient doesn't come to the clinician and say, or to our clinics and say, oh, the reason why I'm here is because I got anticipatory anhedonia. No one talks like that. What they say is, I don't know what's wrong with me, but I'm really tired. I get no motivation. I get no interest. And that was really linked to suicide in our analysis. And these were two study results that showed that the greater the degree of anhedonia on the abscissa, the less likely Prozac drugs work. In other words, one of our standard treatments for depression are SSRI antidepressants, and they work for many people, as I said. But the more anhedonia you have, at least proxied by this measure on the abscissa, the less the SSRIs work. So in addition to thinking about how can we, in an innovative way, learn from our neuroscience and neuropharmacology to develop new therapeutics, it's also about trying to do a better job at targeting specific symptoms. Now, everyone probably knows, without taking a course in lipidology, that in cholesterol medicine, there's different types of cholesterol. And if your clinician says to you, you got really high cholesterol, you're probably going to say, well, can we lower it? But your clinician might say to you, your cholesterol level's kind of high, it's okay, but your bad cholesterol is really high. And there's a reason why it's called bad cholesterol, because that LDL cholesterol is disproportionately contributing to cardiac risk. And using that as the metaphor, anhedonia in depression isn't just another symptom of depression. It punches above its weight, if you will, with respect to how much it contributes to impairment of quality of life and function and suicide. So we don't just want new therapeutics informed by neuroscience and neuropharmacology. We want to have therapeutics that can do a better job at treating some of these more recalcitrant, more difficult to treat quality of life, frankly, human capital destroying phenomenon like anhedonia in these patients. Another area is anxiety. I just was talking to a colleague 1 hour ago. In fact, that's why I was running a bit late at a meeting. We were talking about anxiety. Anxiety is a very common symptom in depression. In fact, 75% of people with depression have anxiety. And anxiety can be a standalone disorder, like generalized anxiety or panic disorder or social anxiety, sort of things like that. And the more anxious people are, the less the antidepressants work, and they often end up taking additional therapeutics and cognitive therapy and so on. So again, this is part of this whole idea that we are trying to figure out what's the best way to treat depression and what's the best way to think about treating depression with anhedonia and some of these other common features like anxiety. Now, I want to introduce something we've been working on in my lab for a long time. I call it the metastasis of obesity to the brain. This is a list of variables that associate with a lower likelihood of benefiting from antidepressants. And one of them is the presence of obesity, or more specifically, an increased BMI. And also the presence of impaired glucose insulin signaling. And I took an interest in this in my career early on because A, these are very common comorbidities in depression. Just to put a bit of color on that as well, of all people who have depression or bipolar disorder, about 20% have diabetes. That's twice the rate of the Canadian population. And an additional 20 to 30% are pre-diabetic. You can do that math. That's close to 40 to 50% of the population is either pre-diabetic or diabetic. And these conditions occur more commonly in people with depression and bipolar for many reasons. One of those many reasons is because of the overlapping biology, because depression is associated with activation of the stress response. So we have a disturbance in the hypothalamic pituitary adrenal axis, but we also have activation of the innate and the adaptive immune system. And we have alteration, consequently, in insulin signaling. And so this contributes to depression and anhedonia and cognitive impairment, and also seems to decrease the likelihood that antidepressants work. This just puts a bit of numbers. This is some data from our lab looking at how common this is. It's very common. This is looked at as odds ratios, whether you like odds ratios or just simple percentages. If you remember 30 to 50%, 40 to 50% have it, you're going to be right. That's what we know. And I wanted just to mention this topic of insulin in neuroscience because it's something I've been studying now for 25 years, 27 years. Here in Toronto, or in Toronto, I'm in California now, but in Toronto, well, we should know insulin well. I mean, for those who are maybe less familiar, insulin was, well, first of all, the name insulin, let's talk about the etymology of the word. Insulin is derived from Latin called insula. So insula means island. And in 1916, a person named Edward Albert Sharpie Schaefer coined the word insulin, derived from insula, meaning islets. And because it's known that insulin comes from islets in the pancreas. And in 1922, January of that year, at Toronto General Hospital, Banting and Best treated the first person ever with insulin for diabetes. It was a young adolescent patient with diabetes. And everyone since that time has become very familiar with insulin and its role in glucose regulation. I want to park that for a moment and now introduce a new folder. And that is that insulin plays a critical role in brain health and disease. And that's completely different than its role on glucose. You don't need insulin in the brain for glucose utilization. There are glucose transporters on neurons and glia that uptake the glucose. So insulin plays a role in the brain from the point of view of neurotrophism, that is, it's in neurogenesis. So it's helping promote progenitor neurons become mature neurons. It's also facilitating the growth of those neurons, the trophic properties, also the synaptic plasticity, so neuroplasticity, and also plays a role in neuromodulating other neurotransmitters. And this plays itself out in ways that are interesting scientifically. We do this in my lab, looking at the effect of insulin resistance on, for example, brain circuit activity at rest or during a task, measured with BOLD in the MRI. So we look at the MRI scan, and what we find is that when someone has impaired insulin signaling in their brain, which we can proxy, there are alterations in how the circuits, the networks are functioning in the brain. And this leads to anhedonia and cognitive problems. And we all know that depression overlaps with metabolic problems, but not just depression. Over 24 mental illnesses are highly linked to diabetes. In fact, I gave a group a few days ago a pop quiz. What's the mental illness with the highest overlap with diabetes? The answer is sleep disorders. And by the way, for those of you who like to be sleep deprived most of the time, like me, not good, that does very much contribute to insulin resistance and inflammation and increase in lipids. It's not a good thing to do to yourself. But anyways, I bring this up because we are looking at ways that we can treat depression and bipolar by targeting metabolic systems, not just serotonin, norepinephrine, and dopamine. So hold on to that when we come back to that in a moment. We also discovered that if people who are depressed are given the opportunity to participate in one of our studies looking at motivation, well, guess what? They show lower rates of motivation. Well, that's kind of circular. They have depression, makes sense. But if they're overweight and have major depressive disorder, the far right, they have even greater degrees of motivational deficit when compared to those who are normal weight. And this is because the alteration in metabolism causes a greater impairment in the motivation center of the brain. And this is something we've been learning in our neuroscience work over the last 20 years. And we did a study, this is a different study we did with one of our other students, where we looked at insulin resistance, and I'll keep it kind of succinct, that insulin resistance is along a continuum, and we all have normal insulin response to glucose, and our bodies have a certain insulin sensitivity. And what we found is that people who start to show increase in IR or insulin resistance, they don't have diabetes yet, but they're starting to show some degree of impairment in insulin function. They're less likely to benefit from antidepressants. And we think that's because once you start to have impairment in insulin signaling in the brain, that decreases the availability of the neurotransmitters that we're trying to engage for our antidepressants to work. In addition to that, insulin impairment in the brain results in less neurogenesis, less neurotrophism, less neuroplasticity. And people always ask the question, well, how do antidepressants work? Talk therapy, pharmacotherapy, or ECT, neurostimulation. We believe they work by ultimately correcting deficits in neurogenesis, neuroplasticity, and neurotrophism. And if insulin's not present and functioning in its normative way, that's a blockade. We can't quite correct the depression. And that's probably what's going on in these cases. The other part I wanted to bring up is childhood trauma. This is something we've become very interested in over the last decade and a half. We've always been interested in it as clinicians, but I think the neuroscience around this is astounding, in the sense that if you're an adult and you have a history of trauma, physical trauma, sexual trauma, abuse, neglect, between the ages of 4 and 7, so as a young child, that results in differences in the brain volume. It results in differences in brain function. And not random, it's actually select brain regions that are relevant to cognitive functions, like the prefrontal cortex, areas of the brain responsible for reward, like the striatum, and people who have had a history of trauma show not only loss of volume, but they show an impairment in the reward centers, the cognitive control centers. And we think this is the early biosignature of later depression. And we think it also is why people we meet with depression who have trauma really struggle with those symptoms of motivation and cognitive problems. And it's also why some of our medications don't work as well in people with a history of trauma, in part because of this change in the brain. And then this is probably mediated by inflammation. Now, this is a study I think everyone should read. It speaks to expectancy, placebo response in psychiatry. And I see lots of people who come to my office and they'll say, I don't know why. I say to them, what are your objectives of being here today? And they'll say, I have no idea why I'm here. My doctor sent me here. Okay. By the way, I get that a lot. and a lot of people will say, after I finish my consultation with them, they'll say, I don't want to go on any more medication. I said, okay, let's talk that through, but tell me more. They don't work. I tried this one and that one. My sister took that one sucks, and so on. I hear this all day long. And that's obviously an attitudinal bias. People are setting themselves up for bias. And so one of the important things we try to do is, well, makes sense. Ask me, what type of treatment would you like? Some people say, well, I don't want medication. I want talk therapy. Okay. Some people might say, I don't want talk therapy. I want medication. Okay. And so that doesn't mean we always give or recommend people want. Some people say to me, hey, Dr. Matter, can you recommend some weed? I said, no, I'm not recommending that. So I don't always recommend what people want. But we find ways where we can find goal attainment that is consensusly arrived at. This was a study in 100 people with depression, and half of them got placebo, and the other half got placebo. Now, that's bizarre. When the patient, or not patients, when these patients, they became subjects, signed the consent form said, you're coming into the study for depression, you're going to get either an antidepressant or placebo. So there's deception. And the Research Ethics Board approved this. And the investigators then gave half of the participants a tutorial on what is the placebo response, what influences it. And what was really interesting is after a couple of weeks, visit 3, it turned out the placebo beat placebo. And the people who benefited from the placebo was the ones who did not have the placebo tutorial. And this is such a complex and interesting study, but what it tells us is that there's many aspects around attitudes towards treatment and expectation biases that influence whether you're going to benefit from treatment. And whenever there's a sexy new treatment that comes to psychiatry, I've been around long enough now to see this, everyone's like, woohoo, it works. It's the best thing since sliced bread. And I think, okay, I'm not a Debbie Downer. I'm all for that. That's cool. That's cool. But how much of this is the expectancy, the hype, the so-called Gardner hype cycle? How much of this is, in quotes, the real effect? And then conversely, when people say, oh, these medications don't help me, I wonder, okay, that's quite possible the case. I've seen that too. But how much of this is just the attitudinal bias that's affecting this? This is something I thought you might find interesting. Now, to keep going with this, one point I wanted to mention is that 1 out of 4 people we see with depression has bipolar disorder. And bipolar disorder is mania or hypomania with depression. In fact, it's the condition that attracted me into psychiatry. I thought I was going to become a neurosurgeon. And I met a patient who had bipolar disorder, and I thought, wow, I have to study this illness for the rest of my life. Here I am still studying it. And so it's really something I wanted to emphasize. We'll get into this a bit later on. So I'm talking about depression and bipolar interchangeably. And one other area of research that we do is we do research on screening tools for depression and bipolar disorder, and we disseminate these in different parts of the world. This is the most disseminated screening tool for bipolar disorder around the world now. It's used in the Medicare and Medicaid system throughout the United States and all 50 states, United States, and is used around the world. We validate this in English and also in Chinese. And this is a screening tool for bipolar. So when you go to your clinician and you're experiencing symptoms of what might be depression, we recommend to all clinicians to screen for bipolar. Now, just as an academic and as a scientist, just sharing this with you as young sort of students and all that, it's really important to, when you're approaching research in medicine, to obviously have an area that you're focused on and you're passionate about. It's also important always to not forget the larger public square and how will your findings be implemented. And as we're trying to develop better therapeutics for depression and bipolar, that's, I think, a noble cause. But frankly, that impact is going to be greatly minimized if we don't also figure out better ways to detect and diagnose depression and bipolar in medical clinics across the world. And so we're always straddling the public square with our lab. So we're always trying to take the lab, as they say, neuron to the neighborhood. And that's how we're always thinking about neuroscience. And many on the course this morning might be aware of so-called implementation science. And implementation science is a whole subspecialty of study that looks at what are the barriers and facilitators of implementing new findings in medicine. And it is the case that if we have new discoveries in medicine, they often take years to be implemented, if at all. In fact, most are not even implemented. And so this is something that we do as well, trying to get the neuron to the neighborhood. Now, one of the questions I've been asked for years is can genetics predict who's going to respond to an antidepressant? Is there a test? And I would say this is a work in progress, but it's not ready for prime time. It's something we are looking at. And we're also looking at, is there a peripheral blood test? In this case, an inflammatory marker. Is there some image, a brain scan? Can we do a pencil and paper cognitive test? Is there what's called a biomarker? Well, you know, when you have pneumonia, we use the pneumonia example again. You provide some sputum to your clinician. They culture that to see what bug you got, and that then informs the medication they're going to give you. If you've got diabetes, they check your blood glucose. So there's a biomarker, but we don't have one of these yet to diagnose or treat or select the treatments for mental illness. But it's a work in progress, and we're looking at a whole variety of these. Realistically, a brain scan won't be very useful because everyone can't go for brain scans. It's too expensive. No one's going to do that. But preferably a blood test or some easy to do test. And that's been a very hot area of research. This is data showing that there's a protein called CRP, an inflammatory acute phase reactant. When it's elevated, it might predict better response to some antidepressants than others. But this comes back, look at the red rectangle. This is, in fact, the point I made a moment ago. This is from the World Health Organization. Around the world, high income, low income, middle income, that most people do not persist with their treatment. So when they're depressed, they go to their care provider, they get a medication. Only 24.8%, so 25% of people with depression persist. They just say, the heck, after a couple of weeks, they forget it. Those drugs aren't working. I'm not doing it anymore. Only 5% or so people bipolar. So in addition to having ways to get our treatments into the clinics around the world, we also need to find ways to facilitate and motivate people. This is where psychoeducation, public policy comes in. We're having accurate discourse and availability of accurate resources is helpful. I mean, let's face it, if asked where would you go to look at accurate information for mental illness, a lot of people would say, I don't know. I would argue it's not Kim Kardashian, but you know, people tend to go on a lot of these pop psychology type sites and so on with a lot of nonsense. Now, let's, if we can, talk about something I want to share with you. The therapeutics that we've had in psychiatry, I'm purposefully not getting into all the details of all the medication, but I want to just share with you some real innovation that's happening in the field. This is a medication that we worked on for many years. It's now approved by the FDA for depression. It's called dextromethorphan. So we've had SSRI drugs for decades, and years ago I started using dextromethorphan. Dextromethorphan is called DM. You may have heard of it. It's in the cough syrup. So Robitussin DM, and DM is dextromethorphan, and it is an uncompetitive antagonist of the NMDA receptor, the glutamate receptor. It's also a sigma-1 agonist. In sigma, I call it the sigma enigma. Sigma is an immune modulating target in the brain. And dextromethorphan received the FDA approval as a cough medicine in 1958. It's been around a long time. And we started looking at this as a potential antidepressant a few years back. And now it's approved as an antidepressant in the United States. Now, that's interesting that a cough medicine, DM, is now an antidepressant. It's combined with another drug called bupropion just to sort of boost its bioavailability, make it more, a bit higher concentration in the blood. But the other part is, which is really intriguing, is that this is a drug that works after 1 week. It begins to separate from placebo. Most of our drugs take 4 to 6 weeks to work. This one works rapidly. And it's not targeting serotonin primarily, which is what we've been worshiping at that altar of serotonin, norepinephrine, dopamine forever. Here's a glutamate drug. It's our first oral glutamate drug that we have. And glutamate's so critical because you all know glutamate in the muscle. It's also in the brain. It's the most abundant excitatory neurotransmitter. And just like insulin being so integral to neuroplasticity, well, insulin cannot do what it does without glutamate and vice versa. In other words, you can't have glutamate doing plasticity without insulin, and insulin cannot do plasticity without its partner. So we have, in fact, an interesting drug because it was developed based on the disease model. Another area I was going to just mention briefly is that we have many, many new treatments now, and I'm not going to get into details. It's well beyond the scope of this course, of the names and all of that. I just wanted you to know that we have so many new treatments now, and there's a drug called lumateperone. Again, this is just more for your interest, in the United States, which is now approved in bipolar depression, which is also a glutamate drug. So we actually have these very new drugs that are coming in. Now, this is in fact, let me move ahead here. This is something I now want to segue to. When I talk about glutamate, I'm also talking about GABA. So again, just to remind everybody, glutamate's the most abundant excitatory neurotransmitter. GABA is the most abundant inhibitory neurotransmitter. And when I started in the field of psychiatry, we used to say the reason why you were depressed is you didn't have enough serotonin in your brain, which wasn't really true. It wasn't really the story. Is that you have serotonergic dysregulation. Now, because of the technology, we do a lot of work now using diffusion tensor imaging, where we can look at the tracks in the human brain. And the reason why people have depression, schizophrenia, bipolar, OCD, borderline, whatever the diagnosis is because there's something wrong with the circuits and the networks in the brain. And we now can see these networks, and these networks are not random. They're actually networks that are communicating to each other. And people who have heart disease often have a problem with the rhythm of their heart. And that arrhythmia can obviously be very serious, it can be lethal. Well, the brain has circuits, and when they go into an arrhythmia, you get a mental illness. And the circuits are comprised of neurons and glia, and those cellular systems are comprised of cytoskeleton, which is comprised of protein systems. And our interventions, talk therapy, exercise, neurostimulation, medication, they trigger a cascade of molecular events that reset these circuits. And that's how we think treatments work in depression now, in psychiatry broadly. And the default mode network is one of many networks. It's one that receives a lot of attention. It's why people always get the exam question wrong. When the question says, is your brain using more energy at rest or using more energy when it's active? Well, the answer has to be obvious. It's when it's active. That's the wrong answer. It's at rest, because that's where we spend most of our time, in the default mode network. And that's where we also self-ruminate. And people who have depression will often ruminate and ruminate and ruminate. And that's a disturbance in the interconnectivity structurally and functionally of the default mode network with frontal cognitive control networks. And that's influenced by inflammation, by insulin, by GABA and glutamate. And there's now data to show that in addition to glutamate being abnormal, we've been able to show that GABA is abnormal. And there's something wrong with this excitatory inhibitory balance, EI, excitatory inhibitory balance. And so we started looking at ketamine as a treatment for depression. Ketamine is an anesthetic that was repurposed as a pain medication, now repurposed as an antidepressant. And ketamine and its enantiomer S-ketamine are drugs that target the glutamate system and rapidly alleviate depressive symptoms within hours and improve suicidality. These are the international guidelines for ketamine and S-ketamine, how it should be implemented. And there's lots of data to support the efficacy and the safety as an antidepressant, but also as an anti-suicide intervention. This has been a game changer, targeting the excitatory system of glutamate. And this was a paper by one of our other students, Danica Nogo, showing that, remember I said anhedonia is just like this enemy of the state? Well, this is where ketamine is really, really helpful. So it's not just about a new target. That's academic. We want new targets that help people. And anhedonia is where people are struggling. And that's where we're seeing ketamine really, really helpful in that area, and reducing thoughts of suicide. And those reductions in suicidal thoughts are independent of the effect on depression. And there's really interesting ways now we can prolong the effect, either by giving people more ketamine or getting them to participate in cognitive therapy. So now some of our patients will come, they're depressed, they'll get IV ketamine for 2 weeks, their depression's lifted, and then they'll see their cognitive therapist to keep well over the long term. Now, with respect to ECT, electroconvulsive therapy is still the gold standard in treating really bad depression. It has very bad public relations. It's been stigmatized terribly. Some states, in the United States, in Texas, you can't even get ECT without a court order, and it's not even available in some countries around the world. That's a terrible shame, because it's the most effective treatment in all of psychiatry. And frankly, one of the most effective treatments in all of medicine, all medicine. But the stigma has been terrible. There are side effects with it, like cognitive impairment. We still use it, but not using it enough, right? Frankly. This was a paper published last week in the New England Journal of Medicine, a pretty respectable journal, one of the world's leading medical journals, showing that ECT and ketamine are both rock stars when it comes to treating depression. And ketamine had a slight lead over ECT, but we'll just say for now, both look pretty similar in treating depression. So both ketamine and ECT. I put this in for today's program, the enantiomer. For those of you who've already been through bioorganic chem, you know all your enantiomers. All that stuff comes back to haunt you, because we study racemic mixtures. We also study enantiomers. And this was a drug that I was working on years ago. It's the enantiomer of the racemic mixture ketamine, which is also available to treat depression in Canada in an intranasal device, rather than the intravenous administration of ketamine. And we now have data to show that it's also effective in the short and long term. Now, that's Glutamate, let's talk about GABA. GABA levels, we have shown some of our work, this is some of it, that is lower in the brain of depression. And what's really interesting is that GABA is the inhibitory neurotransmitter. It binds to its receptor, the GABA receptor. There's two of them. And one of those receptors is called the GABA A receptor. And now we have figured out that the extrasynaptic GABA A receptor plays a key role in your mood. And so that then inspired us to look at GABAergic drugs. Now, this is something I think you're going to find cool. August 5th of this year, 2023, the FDA is going to decide whether they're going to approve this new medicine. This is called zuranolone. And this is a drug that binds to the GABA extrasynaptic receptor. It is an antidepressant that you would take orally only when you need it. So rather than taking an antidepressant every day for weeks, months, and years, this would be you pop this pill for a few days, and then 3 days later, you're better. And you only take it, we call it PRN, as you need it. And be the first ever GABAergic antidepressant, and the first ever take it as you need it antidepressant only for a few days. And so that's how the neuroscience has translated into innovation. I think a lot of people will be very interested in this. So we have not abandoned our serotonin drugs. We still have them, but we are looking at other targets like glutamate and GABA. Rather than focusing so much on serotonin, we've been looking at the role of amphetamine type molecules, looking at dopamine as one other example. But this is something else called the opioid system. Now, Canada, the United States has a terrible opioid crisis because people are using opioids for misuse and recreational purpose. That's obviously very dangerous. And a lot of this, as you probably have heard, has been adulterated with fentanyl and carfentanil, very high potency opioid agonists, which can be very lethal. Opioids are not only relevant to pain. Opioids are relevant to mood, to cognition, to appetite. They're relevant to glucose regulation. And there are 3 different opioid receptors: the mu, the kappa, the delta. And each receptor is different with respect to its endogenous ligand and its functional characteristics. And the kappa receptor is known to play a role in your mood. So are the other 2, but the kappa has been especially attractive to us. This is a medication that we're working on right now called the ticaprant, that's called the kappa opioid receptor antagonist. It blocks that receptor, which improves your mood and decreases your anhedonia. And this is if this is only about a year away from completion, and we can get it across the finish line, will be the world's first kappa opioid receptor antagonist. So we have the serotonin drugs, the glutamate drugs, the GABA drugs. Now we have drugs with respect to opioid systems. What about sleep? Everyone I meet with depression can't sleep or has problems with sleep. And sleep is a very complex behavior because sleep is linked to just about every psychiatric and medical problem. And we use cognitive behavioral therapy to help people get to sleep. That's the treatment of first choice. But many people can't access CBT for sleep, or they don't benefit from it, or they don't want it. And so therefore we use medication. And medications for sleep are many. Again, I'm purposely avoiding lots of detail of the meds, but these medications not only help for sleep, but help your mood. This was a study with one of the sleeping pills showing that it can even help suicidality. And there's a system I want you to be familiar with called the orexin system. This is totally cool. The orexin neurons were just discovered in 1998. That makes these very recent. And the neurons that produce orexins are located in your lateral hypothalamus. And at the University of Texas Southwestern and at Scripps in La Jolla, California at the same time, investigators discovered that the orexin neurons produce proteins called orexins or hypocretins that are playing a critical role in arousal, vigilance. And when the animals have these neurons blocked, the animal develops narcolepsy. So narcolepsy is when you have sleep attacks. Just out of the blue, you just fall asleep. And often it comes with muscle paralysis called cataplexy. And in human beings, narcolepsy with or without cataplexy is a consequence of a lesion in your orexin-producing neurons. Given the role orexin plays in arousal, it was then determined it plays a role in insomnia. And these are drugs that are now available in Canada to treat insomnia. But the orexin system also plays a role in reward, cognition, the stress response system. And what's really interesting is that we are now in the very final months now of developing an orexin antagonist to treat depression because of the role orexin plays in stress response, in cognition, and in reward. So again, another new way to treat depression. I think everyone's been hearing about psychedelics. Psychedelics have received a lot of media attention, and we are just finishing the last patient of Canada's first ever study with psilocybin in adults with depression in a controlled trial, just finishing it up. And these so-called psychedelics, there's many of them, have very complex effects at receptors, notably the 5-HT2A receptor. And the 5-HT2A receptor is thought to play a critical role in mediating the effect of these medicines. And there's been some preliminary studies, not the final studies, that psilocybin might help people with depression when combined with supportive psychotherapy. We are doing the country's first ever study with this intervention in TRD, treatment-resistant depression. And I can tell you that for every question that we've answered so far, we probably introduced another 50 questions. So this is still a work in progress, but to be absolutely and unequivocally clear, this is not ready for clinical recommendation at this point. This is only recommended for researchers to be studying. And in the next year to 2 years, we're going to be in a go, no go position. That is, if it works, we might be in a go. Let's consider this in some people. Or if it doesn't work and or not safe, we'll be in a no-go position. But this has been used for people who have cancer, end of life, palliative conditions. And we have some data not only in depression, but also in trauma and also substance and alcohol-related conditions that this might be helpful. Remember earlier I said that insulin plays such a key role in the brain and metabolism? Well, this is how neuroscience and curiosity could change how we think about treating depression. We discovered this in my lab, and we also discovered there's another type of protein called GLP-1, glucagon-like peptide. It's also in the brain, in the reward and cognition areas, and we discovered that when we give agonists to these receptors, we can actually improve mood and cognition. We did some of this work in my lab over in in Asia. And now we've just started a study with a drug called Ozempic. Now, this is a drug no one heard of before Elon Musk and Kim Kardashian started talking about it, called semaglutide. This is a drug for obesity and diabetes, but we've been developing this type of medicine to treat depression, unrelated to diabetes and obesity. And we've talked about serotonin, glutamate GABA. We've talked a bit about the opioid system, the orexin system, now the GLP-1 system as ways of thinking about treating depression. To wrap it up, transcranial magnetic stimulation is highly effective in treating depression. This is part of a suite of neurostimulatory approaches. This is a very accelerated protocol developed at Stanford. And ECT, this was a paper we did in JAMA recently showing, I told you earlier, this is a strong treatment, is comparable, it seems, to ketamine. And talk therapy is clearly effective on its own in depression. If patients' depression become more chronic or recurrent or treatment resistant, we prefer, in fact, to do combination approaches with medication. And telehealth in digital platforms have made this more accessible, more cost effective, probably made it more destigmatized. And this is a intervention also that we consider to be a gold standard in patients who treat depression. I'm doing a study right now, we have CIHR supporting it, giving people ketamine to alleviate their depression and suicidality, and then switch them over to cognitive behavioral therapy to prolong the anti-suicide effect. So we like the mathematic of 1 + 1 = 3 in this space. So I want to stop there. You go to the Twitter handle for more, just the discussion on these matters. Feel free to join me anytime there. And you can see my my email, and I'd be happy